Thank you. Thanks for joining this afternoon for our GAPP MASLD MASH Community Network presentation on MetALD. I'm Jennifer Geremia. I'm a physician assistant currently practicing at Brigham and Women's Hospital in Boston. So thank you for joining today. So let's kind of jump right into it here. So we're going to sort of look at the breakout between metabolic steatotic liver disease and MetALD. So metabolic liver disease with alcoholic liver disease and how they overlap and kind of differentiate the two and approaches to these patients as guidelines stand. As I already indicated, my name is Jen Geremia. Again, thank you for having me. I will leave this up because I do believe you need to scan the QR code to get credit for today's meeting. So if you do want to take a moment to scan that, I do think also it's available in whatever email confirmation you receive for today. So let's look at this patient. So fairly typical metabolic patient. So she's a 52-year-old female, BMI of 29.4. So she's, by definition, technically, we know the limitations, right, of BMI, but by definition, she's not quite yet class 1 obesity, right? That's 30 or higher. So she would still fall within the overweight category of 25 to 30. She had an abdominal ultrasound that revealed, so she was sent to GI because of this abnormal ultrasound that revealed mild hepatomegaly with increased echogenicity consistent with steatosis, which is fairly common. And I often say, you know, in my baby PA days, I've been in practice for 18 years, you know, we would sort of see this. I mean, the hepatomegaly is slightly concerning, but the echogenicity of steatosis, we didn't really have a lot to offer these patients other than a conversation about limiting alcohol and sort of lifestyle modifications. She is completely asymptomatic. So yet the nefarious part of sort of smoldering liver disease like MASH and or even with alcohol, because by the time they present to us with symptoms, they're usually cirrhotic and decompensated. So looking at her medical history, she does have some metabolic risk factors here. So PCOS, we know, lends itself to insulin resistance. She's got hypertension and hyperlipidemia. So 3 risk factors here in terms of metabolic disease. On exam, fairly unremarkable exam. Certainly, we know due to body habitus and larger BMIs, we may not be able to feel that nice, smooth, non-tender liver edge. But in this case, the examiner did, and she reports drinking 2 glasses of wine per day. Medications, so antihypertensives, anti-lipidemia, multivitamin, and sort of milk thistle, right? That's sort of advertised in every sort of liver supplement or liver cleanse. OTC patients tend to sort of gravitate to some of that marketing regarding milk thistle. Slightly high BP in the office. Again, BMI slightly in the overweight, not quite yet the obesity category. We do see here some mild transaminitis. Billy is normal. Platelets, of course, are important in liver workup because thrombocytopenia is often, you know, cirrhosis till otherwise proven. A1C is in this pre-diabetes category, commiserate with her insulin resistance, and she does have some borderline high triglycerides. So we know she's on a statin. We also know folks with slightly higher sugars tend to trend higher in their trigs. So if we look at where our patient falls, so she's the blue arrow here. So looking at sort of the spectrum of results. So assuming this patient comes to us with abnormal liver findings, okay, she has steatosis. I caution you on the 2 drinks a day. We'll get into that momentarily, but looking at the spectrum, right? If you are able to offer her a FibroScan as part of a comprehensive liver workup, and you've ruled out causation of all other types of liver disease beyond this point, she falls at 11.4. So this certainly by range is going to fall into an advanced fibrotic patient or significant fibrosis patient. So F3, we know F4, right, is cirrhosis, compensated or decompensated. And she does have a fair amount of steatosis by CAP score. So kind of looking at how we then break this down, and right, patients are not always particularly forthcoming with their alcohol use. So how we break it down is either weekly or daily alcohol intake by grams of alcohol. Okay, so looking at how, is it more MASH? Is it more alcohol? Where are they going to fall? So weekly intake, the range is actually quite generous. It's 140 to 350 grams for females and 210 to 420 for males. So that averages out 20 to 50 grams daily for females and 30 to 60 for males. By EASL guidelines, theirs is a steadfast 20 for women, 30 for men. And so that's equal to about 2.5 to 3 drinks, depending on what they're drinking, as far as that breakdown. So by patient reporting alone and no other biomarker, you could do a quick sort of calculation based on, okay, if it's 2 per women per day, which is our patient, right, per her reporting is 2 per day, and you calculate her grams, per week, where does she sort of fall in that spectrum? And theoretically, if 20 were it, so you see the top is weekly and daily is below, then she would fall more in the MASLD predominance, okay? Versus someone who is much more heavier in the alcohol predominance. And then, of course, like I alluded to earlier, right, we see our liver patients, we've ruled out any and other all causes of liver disease. If you see a patient, whether it's abnormal LFTs or you've identified fibrotic disease, we can make assumptions all we want that it's liver, that it's fatty liver, but you do have to make sure that there's no other reason, right? So some type of genetic anomaly, autoimmune pathogen, drug-induced liver injury, etc. So this is just a diagram looking at sort of equivalencies of alcohol percentage. Now, this doesn't always necessarily translate into how many grams, which is what we saw earlier, but right, patients have like these wonky ways of expressing how much they're consuming, right? It's just a glass of beer, but it's, double what a standard glass size would be. It's in like those big, Stanley Cup type mobile cups. Or I only drink beer or wine. I don't drink hard alcohol. And this just sort of gives you a typical serving size of alcohol content. So if we go by typical serving size and grams, right, 2 glasses of wine generally is about 20 grams, so 5 ounces. So just a little visual to put into perspective. I think it's actually more helpful for patients, but that percentage of alcohol content varies in terms of the grams that the patient is consuming. So what's happening here? So now we've got sort of dual insults on this patient's liver, right? So this particular patient has multiple MASLD risk factors, or NAFLD, the old nomenclature, right? She's got insulin resistance, she's got right at the cusp of obesity, and she has hyperlipidemia and hypertension, right? So sort of classic kind of metabolic syndrome risk factors here. And then obviously we know with ethanol and alcohol that in and of itself is toxic to the liver, leading to inflammatory response. And the two together, right? So we know most of our cholesterol pathways and lipid pathways occur in the liver, hence why statins work in the liver, right? But the oxidative stress between the increased lipogenesis and storage of fat in the liver, plus the toxicity and chemokine upregulation and macrophage inflammation and activation that occurs, that the two together, and I think anecdotally this makes sense, you now have an accelerated rate of inflammation leading to fibrosis and disease progression. So how much time, right, do we have to intervene? So really the key is identification as early as possible for both sort of drivers of liver disease. And so looking here at risk within a 5-year period of time. So our patient was like at around 11, right? So she technically falls into the F3 category. And risk to decompensation, so basically transplant level of liver disease or death, right? What does decompensation mean? You're either going to die of liver disease or get a transplant, basically, right? And what is that risk? And we see that if it's MASLD, it's about 5 to 15% within a 5-year period. If they have the combination of two, that's highly accelerated up to 30%. And then if it's alcohol predominant alone, then we're heading up to 15 to 50%. So huge range. Again, we know that fatty liver is replacing all other causes of liver transplant reasons in women, and second all cause in men, with alcohol being number one for males, but nevertheless quite significant, irregardless. And 5 years really is not a long time in the spectrum of someone's longevity. And so if we look at if these patients continue to have poor metabolic outcomes with progression of diabetes, hyperlipidemia, et cetera, of course, that's commensurate with more accelerated disease. But we also know, of course, the more alcohol that they consume, that risk is higher. So I think a lot of this is fairly intuitive, I should say. I shouldn't say anecdotal, but intuitive. But I think the rate of acceleration is quite fast. So the impetus is for us to identify and treat and intervene. And if it's alcohol, then intervene in that manner, if that's where they need the most help. But knowing that it needs to get addressed. So how do you start addressing alcohol more by biomarkers and not just patient reporting? Because we know that, especially if they're new to you or it's an emergency room setting, that they're not terribly forthcoming in terms of that. So we really sort of have shifted. And I will be honest with you, I use biomarkers in my practice as part of liver workup, whether it be a fatty liver fibrotic patient, whether it be someone coming to me for abnormal liver functions. I'm honest with the patient. I tell them I'm going to order it. I'm ordering Hep C, right? Like I tell them, hey, this is what we're, looking for: infection, autoimmune, toxicity, including alcohol. Sometimes that spurs a little bit more forthcoming answer from the patient. And we've already saw the risk factors for progression in terms of steatohepatitis and the combination of the two leading to decompensated cirrhosis. So we're going to look at blood biomarkers in a little bit more detail in a little bit, but looking at how some of this data came to be. Now, this data is a little bit antiquated. It's from 2022, but they basically took a standard questionnaire called the AUDIT-C, so patient-reported outcomes, that asks how many days of the week do you drink? When you do drink, how much, right? Is it a binge versus maybe a glass of something? And so then it looks at frequency and intensity of drinking, basically, and it gives you a score. And so looking at the scoping review, that's what SCR stands for. It's looking at sort of the breadth of evidence and how much you can pull in from evidence that's available to provide some insight on reliability. So we taking again into metabolic risk factors and then looking at things like MCV, right? We know a high MCV can be commensurate with micronutrient deficiencies from alcohol. Of course, GGTP or a high alk phos can be indicative of some type of early fibrotic disease. Also looking at metrics like their ANI score. And then you can also do biomarkers within of course, yes, you can do blood alcohol levels, but that's sort of very much in the moment. Doesn't really tell you beyond a matter of hours, right? And so you can do these biomarkers, urine ETG, hair ETG, or FAEE, which are a little bit more antiquated. We have better serum biomarkers now. And so looking at this, the hair ones are kind of interesting because they do hang out for a while. FAEE in particular is sort of derivative of alcohol that gets secreted through the sebum in the hair. Now, like if you have just had your hair dyed, it could skew the test. So there's some limitations there, but kind of sticks around for a while, similar to when you think of the fact that marijuana is fat soluble. So in this particular analysis, they looked at these sort of metrics and how kind of reliable they were as far as optimization of diagnostic means, right? And so what they found was about 28.6% of NAFLD patients were using moderate to excessive alcohol consumption. And so in the diagnostics, so AOC is sort of analysis under the curve if you're a statistician, and anything really like above point, you want it to be as high above 0.5 as possible. So the hair ETG, not surprising that it's higher because it sticks around for a long time. So it's got some longevity there. The AUDIT-C is a patient-reported outcome. So, patients are not always forthcoming as far as that analysis. But really what this told us is that we sort of need to shift towards a more objective biomarker method of being able to assess these patients. And certainly there is a lot of gaps as far as how you define this, but it needs to be on the radar. So we've already sort of talked ad nauseum about risk factors, about metabolic dysfunction, high blood sugars, high blood pressure, high cholesterol, low LDL, high BMI. That's sort of the classic definition of metabolic dysfunction. Does the patient have isolated hypertension or hypertriglyceridemia. Yes, but yet they have steatotic liver disease, right? So we're not looking at fibrosis here. We're just looking at the simple presence of steatosis. Okay, so if they have these risk factors like hypertension or hyperlipidemia, yes, then consider using some biomarker like PEth testing to assess for undisclosed or underreported amount of alcohol use. If the patient has other metabolic risk factors, but no hypertension or hyperlipidemia, then it probably is just MASLD, assuming that they're not, that you trust that they're not reporting any alcohol. And I'll explain why hypertension and hypertriglyceridemia were the benchmarks there, and we'll look at that bidirectional relationship with alcohol in a moment. So you want to try to get some gestalt of what the grams per week is with the patient. Again, is it binging? Is it daily? And kind of what that looks like. And do they potentially have true blue alcohol use disorder? The biomarker that's readily available, I think that's used the most, that's sort of evolved, is PEth testing, which I think is pretty readily available everywhere. Just make sure you're coding for either moderate alcohol use, hepatic fibrosis, abnormal LFTs. Just make sure you're coding that correctly for diagnostic purposes. When we look at a patient that is using alcohol, whether it's disclosed or through a biomarker, patients that, again, fall between 150 to 350 per week for males, 210 to 420 for females is where the range is, and the PEth varies. So PEth testing basically is going to be around for 28 days. We'll look at a slide of that a little bit later, but just to give you the range, anything basically under 35 is considered low to no use. Anything between like 35 and 200 is moderate, and then above 200 is excessive alcohol use, just to give you some framework. So they would otherwise fall into that MetALD category, and more alcohol use liver or alcoholic liver disease is going to be patient reported, very high grams per week, over 350 for males, females, 420 for females, and a PEth test over 200, like I indicated. So then that's tipping us over into alcohol use disorder. And again, making sure that there's no other causation for a liver disease. So it's just kind of highlighting that. So looking again here at the PEth ranges, our patient fell at 120. So she did report that she was doing 2 glasses of wine per day. So she did report that, but that is fairly moderate daily use, right? It's not a binge, but she is using alcohol every day in terms of the range. And again, sort of expressing to the patient that you have this number and, really teasing out how much they're drinking. So after a binge, it's valid in your bloodstream up to 12 days, but more moderate use, it sticks around up to 28 days. I often liken this to the A1C of alcohol, right? It gives you that more long view lens. It's more practical. It's a serum test. We're not taking hair follicles in clinic, right? As far as the levels here. And so also too, if we look at the fact that it doesn't matter if you're male, female, overweight, not overweight, that the test is equally reliable, irrespective of those different variables there. And so what we see in the gold here in our chart is really blood alcohol levels. And again, is it going to be more of a binge versus moderate regular use? And so I mentioned earlier, we're going to talk about the bidirectional relationship between hypertension, hypertriglyceridemia, and alcohol. And so in this analysis, they started with about 659 folks, and they really whittled it down by criteria or exclusion being mostly other types of liver disease or BMI benchmarks. And they reached 97 patients that sort of fit the mold to be quantified as MetALD. And so 15.7% of that 659 were at risk of being MetALD. So going back to our patient case, again, she has multiple metabolic risk factors. And the bidirectional relationship, so she also has hypertension. So looking at that cohort of the 659 that got whittled down, right? Looking at a review of evidence-based medicine, right? In that 767 patients, they saw this relationship between BP. Now, it's not surprising that the BP drops after consumption of alcohol, right? Hence the downer relaxation effect of alcohol. And so that's not, again, that's intuitive. But what's interesting is after about 13 hours of consumption, blood pressure starts to go up. And so there seems to be this inverse relationship after that time point. And then if we look at triglycerides, now whether this has to do with more of the sugar concentration of alcohol, because we know that it has a high glycemic load in that relationship with triglycerides, it's not entirely clear. But we also know that triglyceride concentration after 10 hours of alcohol consumption, and they compared it to water, so essentially a placebo arm with no alcohol. So that's our patient, 2 drinks per day, right? That there is a elevation of triglycerides that occurs after that drink. And so there's also a bidirectional relationship there. And so the alcohol in and of itself is a risk factor for cirrhosis and fibrosis. And then you take the fact that they also have fatty liver, and now the alcohol is directly affecting the metabolic risk factors of hypertension and hypertriglyceridemia. It's like a hamster wheel where they're sort of feeding off each other and all fulfilling sort of inflammation that is causing risk for fibrosis within the liver. And so this is just sort of a refresh in terms of how this patient presented all in one screen here. So she has fatty liver with predominant MetALD. And what got us there? The metabolic risk factors plus her PEth test and her self-reporting of the 2 drinks per day. So that meets the qualification there of about 20 to 30 grams for women per day. So what do we do with a patient like this? One, obviously, really educating and eliminating the alcohol, potentially referring to substance abuse if necessary, and or psychiatrists. I think GIs or hepatologists have a variable comfort level with utilizing secondary agents for alcohol use disorder, whether that be naltrexone or Vivitrol, whether that be things like antabuse. I've seen in my time variability in people's comfort levels there. Of course, lifestyle modification and good management of the metabolic conditions. Is the patient a candidate for resmetirom? Yes, they're an F3 fatty liver patient. It is not counterindicated in MetALD. It is counterindicated if they fell into that predominant alcohol, like the over 300, right, PEth patient. That is, okay, this is alcoholic liver disease, right? It's not indicated for alcohol liver disease, but it's not contraindicated in MetALD. So really it is important to sort of parse that out. Because they're an F3 fibrotic, they do need hepatocellular carcinoma screening. So AFP, and then our alternating ultrasound and MRCP to look for hepatomas, because we know many HCC cases do arise from fibrotic patients that were not deemed to be cirrhotics. So ideal, again, sort of how you define MetALD, and this is certainly something that needs more parsing out. But one, really overcoming underreporting use of alcohol use disorder, and biomarkers are very helpful in that way. And PEth testing, I would argue, is the way to go. And standardize this assessment of alcohol use. And also you can use it to prove that they've been abstinent, right? So whether that be for transplant purposes, if you have a cirrhotic, or whether that be, just for confirmatory purposes of what the patient's reporting, it's helpful in either direction. Consider, is there more than one cardiometabolic risk factor, but in particular hypertension and hyperlipidemia, and see what happens with hypertension and their lipids after alcohol use is discontinued, right? Do those level off because of that biphasic relationship, or are they still present and in and of themselves as independent risk factors need to be addressed? And, looking at the last 6 to 12 months, not what happened 20 years ago, I was an alcoholic, what's happening sort of today, to be able to make that assertion. So in closing, remember that we have the definition of MetALD, so overlap of metabolic liver disease along with alcohol liver disease of moderate degree. 140 to 350 grams per week for females, 210 to 420 for men. And patients, of course, we know underreport their alcohol use, so rely on serum biomarkers like PEth testing. Also ensure that there's no other reason that they have liver disease and reassess their overall metabolic function over time. And of course, minimizing exposure to risk factors. So if you have identified patients that have liver disease, offering them hepatitis vaccinations, etc. Of course, we need more ongoing research to really sort of hone in objectively on the definition of MetALD, but it is a new diagnosis, so more to come in terms of how we actually define that, and also allowing for different comparisons between socio and cultural sort of realities, in particular around alcohol use disorder, but also MASH, right? We know that Hispanic patients do have a slightly higher propensity towards fibrotic disease when MASH alone is present. So certainly we know that there can be some cultural variability there. So thank you for joining us. We're at the end of our time. I wanted to allow a few minutes for any questions. This is another QR code different from our earlier one to connect to other MASLD and MASH resources, disease state education, and also some targeted information regarding resmetirom for the use of MASH. So feel free to unmute yourself or put any questions in chat if you're not comfortable with unmuting. And thank you again for joining.